Welcome from CVI 2017. I'm Dr. Michael Luna here with Dr. Zaher Fanari, who will be talking about Transcaval Aortic Access for Percutaneous Thoracic Aortic Aneurysm Repair. Welcome.
Thank you very much for having me here today in CVI. It's very exciting to present this case. So today I'm going to talk about this special case where we did transcaval access to perform thoracic aortic aneurysm repair. These are my co-operators in the procedure. So case of objective basically to discuss alternative access for thoracic endovascular aortic repair, TVAR, if you have very diseased or small or occluded iliofemoral system. We have this gentleman, 65-year-old, with past medical history of coronary artery disease. He had VCI to the LAD in the past, where he was found to have this thoracic descending aneurysm, which we were following for years. So basically, he comes to us for follow-up in 6 months, and his aneurysm goes from 4.8 to 6.3 within 6 months. So we felt like this is actually growing really fast, so we decided we have to fix that. Patient physical exam, except for the aneurysm, actually, nothing major except for grade 2 systolic ejection murmur. He had actually mild to moderate AS at the same time, so that was from that. So the CAT scan here, we can notice on the CAT scan, this is the aneurysm. You can see that part of the aneurysm is actually thrombosed, but it's really big. So if you look at it here, it's really large, and it's definitely have risk. It's definitely at risk for rupture, especially in this area here. So we decided to fix this. The patient had multiple. He had severe COPD. He was not a candidate for surgery, so we had to do it endovascularly. When we did the assessment for the planning, we actually noticed that this gentleman actually had occluded the right common femoral artery, and the left actually system, the iliacs, was 4 millimeter. So basically, he did not have a good place to put the 22 French sheet that's required to do this repair. So we thought about it, and we decided we are going to do transcaval TVAR repair. So we discussed this with our surgical colleagues who agreed with us. They are part of the heart team, and they did also transcaval with us before, so they trusted that we will be able to do this, hopefully, with good results. As I said, there was no good access on the iliacs, but there was good enough for bailout, and that's very important to say. There's good enough for bailout at the area of the transcaval if we need to fix this, if we couldn't close it. We could go through that for left common femoral artery and put the graft there. So basically, to fix this, we already decided on the CAT scan which the area we're going to cross in corresponding to the vertebra. We always do spontaneous aortic injections to determine also on the table if that area is still the same as we expect it to be. And basically, after we do that, we do actually imaging. We do imaging at 90 degrees. I think there's a slide missing here. So what we do actually, basically, we get a big tail and do the imaging. And after that, we go through the arterial access, and through the arterial axis, we put a snare there facing the IVC. And through the vein, we go with a system, so it have a Confianza Pro 12 wire. We cut the tip of it, 1 millimeter, and we put it in 014 catheter, and we put that in 035 catheter, and all of this system is goes through a Lima guide, a short renal Lima guide. And then we let this Lima guide face that snare, opening of the snare, and we confirm the positions at 90 degree angles. So after we confirm the position, we actually use cautery on the end of the wire and cross with that wire, and then snare the wire, and then get the wire all the way to the descending aorta, and move the 014 catheter on top of that. Then we move the 035 catheter, and basically once we get that, we take the 014 wire and catheter out and put stiff 035 wire. And once we do that, we are able actually to put, on that wire, we are able actually to put, you can see the guide here going from the vein to the artery. We can put that 22 French sheet there. Obviously, you do the same for Transcaval when you are doing, where you are doing TAVR as well. So here you can see the aneurysm before the repair. The repair itself actually was really the easiest part of it. So once we have the sheet in place, the patient is stable, we went ahead and deployed the graft. We used 32 by 32 by 150 millimeter endograft. We got really very good results. You can see actually here the shadow of the aneurysm, and you can see we excluded the flow to it very well. And there's no extravasation at this point. So now at the end, we have to blend the closure. So here you can notice this is the sheet going from the vein all the way to the artery. We have a big tail going from the artery. So basically what we do, we have this 14 French sheet. We prepare the closure system. So what we use a G-less defectable sheet. It's usually it's 8 French sheet, and inside of that we put what we are going to use. We got really good results with closure with using BDA occluder devices recently. So for this, usually we use actually 10 by 8, but this is 22 French sheet, so we chose actually to use 12 by 10. So what you do, you get this Aegis sheet all the way there. Then you have to retract the 24 French sheet over this. And you have to retract it all the way to the IVC. If you keep this in the track and you don't get it to the IVC, the patient will be bleeding actually from the aorta. So what you do after you track the sheet here, you can notice that the major big sheet is here. Then you deploy, you retract the Aegis sheet and deploy the first disc, as you can see here, and then you push the other disc as well. And at this point, we did that. And what you want to do at this point, you do this and actually you wait for 10 minutes, as long as you know there's no massive bleeding. So you can see there's some flow between the aorta and IVC, and that is okay. That's even acceptable if this is what we call type 1 leak. This is even acceptable at the end of the case. But what we do usually, we keep this for 10 minutes, take another picture 10 minutes before we release the device. So here you can see, we didn't release the device yet. Basically, you can see there's no flow at all. So this is no residual leak, there's no perforation, there's nothing going on there, so you can release the device. And then at the end, you can close the peripheral, the vein side, you can just do a figure of 8 stitch there. Some people do bear close as well. I think both ways are acceptable to deal with the vein. So here you can see the CAT scan next day, and you can see the closure device actually staying there. And you can see there's no bleeding around it. You can even see the part of the aneurysm here, and you can see the graft doing here. You can see so the graft looked really good as well, so that was not an issue. The patient really did well and actually went home on third day after the procedure. So the take-home message is basically that Transcaval access may offer a reasonable alternative access to perform TVAR in patients with disease or small iliofemoral arteries. I want to thank my co-operators, Dr. Nilesh Goswami and Dr. Jeffrey Goldstein, for their help in this case.
Very nice.
Thank you very much.
So a couple of questions. Yes. How do you decide, do you always use ADOs, just regular ADOs for this, or how do you decide, is there anatomy criteria that chooses one versus another?
Right, so people usually, they used they used to use VSD devices before. I think now we are using BDAs. We feel, most of the time you have to, I think you can, you always blend the procedure to use with occluders. There are much better results now reported with BDA occluders than VSD occluders. So that's why people are using that more. The size of the occluder, it really depends on the size of the sheet you're going with. So if you're going with 14, 16 French sheet, what we were doing recently is using BDA 10-8. In this case, we used 12-10. Obviously, we were not 100% sure it's going to be enough to close this. But what you can do sometimes, actually, if you get some extravasation, what you can do, you can go and balloon the aorta at that site. That actually will flatten the inside the aorta disc more and push it towards the wall. So actually that will help, regardless of if you get to choose smaller size than you should, and you already deployed this and you don't obviously want to take it out and put another one, I think that's a good solution to deal with that. You have always to plan also a backup plan where you can use a graft through the other groin. So you have to know what size of graft you need to use in the aorta, depending on the size of the aorta, and what size of sheet you need to get, and what is the diameter of the iliac system you have, and whether that will be enough for you to get the sheet up and to deploy that graft. So you always have to plan a backup plan for the closure as well.
Yeah. What complications have you seen with these transcaval closure devices outside of leaks? Have there any reports of IVC issues with devices sticking into the IVC a bit?
We did 13-hour center. We didn't see any major issues. Most of the time, you're deploying this on the aortic side. You really don't need to do anything on the IVC side. However, obviously, there are situations where the IVC and the aorta can be very close. I think if you need to be aware of that, then you may want to use either a device with longer waist or elongate the waist before deploying the second disc you have. So you have to plan that ahead of time. So that's why CT planning before the procedure is very, very essential. You have to study your imaging very well, study the area you're getting your access. Make sure actually you get your access in that area, obviously, when you are doing the transcaval access. And basically, it's all about planning. So if you do very good planning at the beginning, your risk of complications goes way low. If you did not, obviously, you can get in trouble very easily.
All right, very good. Thank you so much. That's a great case.
Thank you very much. Thank you.
All right, Dr. Fanari will continue with the complex peripheral case after this.